I'm Dr. Mariannette Miller-Meeks. With all the fervor over healthcare in the United States at this time, I'd like to ask you to join me in a candid conversation about our healthcare system in the United States. We can discuss what are the attributes and the deficits of the current healthcare system. Would competition work to help control cost? How does competition work? The fallacies of prevention and electronic medical records, and any alternative systems that would be available to help contain costs and afford access for everyone to health care. Let me give you a little of my background. I'm currently an ophthalmologist in a rural area in Iowa, but prior to that I was on the academic faculty at the University of Iowa and the University of Michigan. However, I started my career as a nurse, both in the Army and in the private sector. I've also been a nurse and a physician in the military, so I have some insight into not only healthcare as a physician, but as a nurse, an employee, a private practitioner, as a self-employed individual, and also single-payer systems within the military. Let's have our conversation and start first with the current healthcare system and its attributes and deficits. Our current healthcare system is one of the best in the world. But we do have a problem with people having access to care and the affordability of care. Let me give you an example. Everyone wants to have a Cadillac, but not everybody can afford to have a Cadillac. Because everyone can't afford to have a Cadillac, we don't say that we have an auto manufacturing problem. But when it comes to healthcare, everyone wants to have the Cadillac of healthcare, but everyone can't afford the Cadillac of healthcare, and that includes the taxpayer. But we don't say that we have a financing problem in healthcare. We say that our healthcare system is broken. We have the finest healthcare system in the world. We know this by the number of physicians who come to our country to learn, to get educated, and to practice here. Often, after they have developed a skill set and have practiced in the United States, they may return to their home country and set up a rapid healthcare system there. We also know that the quality of our healthcare is high in the number of people who come to the United States as a recipient of our healthcare system. Our cancer cure rates are among the highest in the world. The Canadian-US study has indicated that our cancer cure rates are higher in the United States than in Canada, which has a single-payer system. We also see this in the access to new technology and new procedures that occur in the United States, for which may be prohibited in other foreign countries that have a single-payer system. Let me give you an example. A study published last year in Lancet Oncology indicated that the 5-year cancer survival rate in the United States was much higher than in Canada. Also, similar studies have shown that the access to preventative care and treatment for chronic illness is much greater in the United States than under socialized medicine in Canada. Further, in 2007, there was a publication in Healthcare Economics and Policy which reveals that the care of the poor under socialized medicine compared to the non-poor is much worse under socialized medicine than their American counterparts. There is a trade-off, though, in access to specialty care versus access to basic care, which is lacking in the United States. One of the criticisms of the United States healthcare system is that our mortality rate does not mimic those of other single-payer countries. Therefore, they use this figure as a way to denigrate the U.S. healthcare system and state that we don't have the quality that we think that we have. However, that figure is slightly misleading. For instance, within the mortality figure encompasses everybody in the United States, whether they're a recent immigrant or they have lived here their entire lifespan. We know that it takes 2 generations in order to adopt the lifestyle and the health status of the country to which one has immigrated. So an individual who has immigrated to the United States will have the same mortality figure as the country from which they've immigrated for 2 generations. So if someone's immigrated from Ethiopia or from a Central American or South American country or an African country or Asian country where the lifespan is less, it takes 2 generations to work through that change in health status until it comes up to where most U.S. citizens reside. So we can see that that number is an artificial lowering. In addition, when you look at the quality adjusted life years in Great Britain, Canada, and the United States, there's really only a 6-month difference rather than a 1-year or 1.5-year difference, as you may have seen in some graphs. If you have a question or comment about this video, please feel free to contact me on my blog, Facebook, or Twitter. Our next video will be discussing cost of the healthcare system.